I'm Regan Williams, the chair of the Committee on Trauma, and these are Committee on Trauma members, and we are going to give you an update on 5 things that are new that happened over the last year that we think are really important for our general APSA membership. We know most of you take care of trauma patients maybe every single time you're on call, but not everyone can be on the trauma committee, and not everyone can keep up to date on the trauma literature all the time. And so we really just want to give you quick shots on 5 things that we consider to be important and things that we want you to know. We will hopefully have a few minutes at the end for questions, so we'll just keep those all to the end, and we're going to try to move right along so that we stay on time. Thank you. I'm going to ask our first speaker, Stephanie Shao, to come up. Stephanie is from Stanford, and she is going to be talking on PTSD.
Good morning. Didn't know I was going first today. That's great. Okay. All right, we're going to talk about PTSD in a very concise nugget of what you need to know. But I'm going to first start with a video. The quality is not great, but you get the idea. This is a video of a patient that we took care of at Stanford. He was assaulted at school, stabbed many times, beaten with baseball bats. It was posted on social media. This was out of nowhere. He wasn't part of some kind of gang or anything. He actually called 911 himself after he was assaulted, and then came to the ER in hypovolemic shock. He spent 3 months in our hospital, and when we saw him back in clinic at several months after his injury, really wasn't his physical injuries that was still bothering him. He wouldn't leave his house. It's not just that he didn't want to go to school, he was afraid to leave his house for fear that this could happen to him again. So why should we care about PTSD in injured children? Because it's a big deal. So 20 to 30% of pediatric trauma patients actually experience some form of mental health distress long after their physical injuries have healed. And about 50% of those who have high levels of PTSD have actually expressed some form of suicidal ideation in the year after their injury. And so because it really has these really long-lasting sequelae, the ACS has now made this a requirement for all trauma centers. So the risk factors for PTSD, one of the really key things to remember that I hope you take home is not whether or not the accident or the event was an objective threat to life, it's whether the patient perceives it as a threat to their life. So the injuries may be minor. It's not, ISS is not a predictor of whether or not a patient will develop PTSD, but if that patient believes that their life was in danger, they are certainly at high risk. And patients that you see in the hospital who have extraordinary levels of anxiety or depression immediately after the injury, they are also at particularly high risk for developing PTSD. And of course, if they have low social support. So this is a busy slide. You don't have to remember it. It's a trip back to medical school. But the things that I want you to take home are that acute stress is what happens immediately after the injury, up to a month after the injury. And then PTSD can be diagnosed by a mental health professional at 1 month and beyond. And so a lot of the things that we'll talk about in terms of screening for PTSD are really early on looking at those signs of acute stress. The other thing you should remember is that symptoms in kids are not going to be typically the symptoms that you think about in adults, right? So kids can have very subtle behavioral changes that very easily can be attributed by their parents or their teachers to just, they're misbehaving. One of the most common misdiagnoses in children who have PTSD is that they were diagnosed with ADHD, rather than recognizing that this is actually a sign of PTSD. And then there are also more subtle behaviors that really take some probing to figure out, for example, withdrawing from friends, or developmental regression, like thumb sucking, or having imaginary play at a developmental age well beyond where you would expect them to have imaginary play. And it doesn't necessarily even have to be related to the accident itself. It could just be imaginary play. And then just generalized kind of vague somatic complaints. So what are we doing right now across level 1 and 2 trauma centers in the US? Only about a quarter of trauma centers are screening for any form of mental health disorder. And only about 30% of pediatric trauma centers have any protocols for assessing mental health, with only about 10 to 20% providing any form of psychoeducation post-injury. So what this means is there are a lot of people who are vulnerable and maybe facing sequelae of PTSD on their own. As I mentioned, the ACS has now made this a requirement for all trauma centers. In addition, there is the best practices guidelines that the ACS has also put out. I, among others here, have contributed to the mental health for children. This is a great take-home slide. If you download that ACS best practices guidelines and just look at this one page, this will get you started. Basically, any form of screening is better than no screening. These are all validated tools. There's no large studies that show one tool is better than the other. In this chapter, we kind of talk about the pros and cons of these various tools and when they can be implemented and what age they're validated for. But really, all of these tools are just helpful in giving you a framework for assessing early signs of acute stress. I'll give you an example of what we do at Stanford. We use the ASC3 and the ASC6 tool. This is an acute stress screener. The 3 and the 6 have equal validity, so we use the 3 because it's easier to administer. Our social workers visit every trauma patient and they administer the ASC3. Those who screen positive will see us in trauma clinic 1 to 6 months later. It's run by our APP, Catherine, who's in the audience here. And then they will receive this QR code when they register for clinic, which takes them to this app, and we reassess their symptoms. So this is what it looks like. They get the screener by the social worker. We have a dot phrase for the social worker's note. They just select their answers, and then those who screen positive will see us, again, with that QR code at 1 month. As non-medical mental health providers, we don't diagnose PTSD. You need a psychiatrist or psychologist to do that, but there are very brief screening tools. This is what we administer in our clinic, and if they screen positive on this, that means at 1 month, they have enough signs of PTSD that you really should be referring them for formal mental health services. Cognitive behavioral therapy remains a mainstay of treatment, and when you're seeing these patients in clinics, one of the things we really want to probe is what the patient's appraisal of the situation and how they're adapting. And that really does require very specific questioning. So not just how the injuries are healing, but in the case of the child that I showed earlier, how's school? How are your friends? What are you doing now? The other thing that we as pediatric providers, we're all very used to doing family-centered care. We understand that parental coping really does have a big impact on how a child copes. So the parents' PTS predictors at 1 year really predict child's resilience. It's not the vice versa. So if the child has PTSD, the parents may not. One of the things we're used to doing is asking parents how their children are doing. And while parents are really great at reporting pain of their children, and there's really a lot of evidence to show that parental and child perception of pain is concordant, it is not true of mental health functioning. And so that's something to keep in mind, that when you're assessing how a child is recovering emotionally, that often you actually interview them separately, both for the parent's well-being and for the child's well-being. So in summary, PTSD is under-recognized, but with a multidisciplinary collaboration in our trauma centers, we can improve that. There's lots of screening tools. They're not difficult to use, and then we can get our kids to appropriate follow-up and treatment. Thank you.
Our next speaker is Dr. Lucas McDuffie. He's assistant professor and the trauma medical director at Dornbecker Children's Hospital in Oregon.
Thanks for allowing me to speak to you today about cervical spine injuries in children. Specifically, this talk addresses an important new study and clinical guideline from PCARN focused on screening for cervical spine injuries in pediatric trauma patients. We have no disclosures. Cervical spine injuries in children can have devastating consequences. If you aren't aware of this, you might be in the wrong meeting. And of course, iatrogenic exacerbation of these injuries can occur if they're not detected and managed appropriately. Given the high stakes associated with missing these injuries, emergency physicians and trauma surgeons appropriately fear missing them, but CT scans are often inappropriately used to screen for these injuries. In the US, 8 million children are screened for cervical spine injuries every year, but only about 1% of these patients will end up having a cervical spine injury. More CT scans means more money and more radiation delivered. More radiation increases the lifetime risk of cancer. As a card-carrying member of the APSA Cancer Committee, I can confidently tell you that cancer is bad and also expensive. So to address this, multiple cervical spine imaging guidelines have been created over the years. You've got the Nexus criteria, the East guidelines, and since we're in Montreal, the Canadian C-spine rule, but all of these have limited applicability in children and specifically in pediatric trauma patients. So which kids need to get imaging to evaluate for cervical spine injury? To address this, the Pediatric Emergency Care Applied Research Network, led by Julie Leonard at Nationwide, published this paper in Lancet Child and Adolescent Health last year and created this C-spine imaging rule job aid. We will go through this on a subsequent slides and briefly discuss the study itself. They suggest 3 risk strata based on reproducible, simple clinical signs. The high-risk group are those patients presenting with a GCS of 3 to 8 and a U on the AVPU responsiveness scale, which means they are unresponsive to any form of stimulus. And according to this rubric, abnormal ABCs and or focal neurologic deficits also impart the designation of high risk, and these patients should get a scan. For those patients who do not demonstrate any of the high-risk clinical findings, the next strata represents an intermediate risk group whereby plain films of the cervical spine are warranted. Diminished but not profoundly diminished GCS, self-reported neck pain or tenderness on exam, or a substantial head or torso injury, defined as those injuries requiring inpatient observation or surgical intervention, or specific associated injuries such as skull fractures, pneumothoraces, pelvic fracture, or other spine fractures. In these patients, you should consider a plain film. But then, importantly, if the patient does not demonstrate any of these risk factors, the clinician should also consider just clinical cervical spine clearance. So how is this clinical rule derived and then validated? This is a prospective observational cohort study. The clinical rules are derived in 9 separate pediatric trauma centers around the country and then subsequently validated in an additional 9 pediatric emergency rooms. The derivation cohort had close to 12,000 patients, of which 274 had cervical spine injuries. The validation cohort had 10,500 patients, of which 159 had cervical spine injuries. And the authors stratified these patients as the first set of 9 hospitals based on which risk factors were associated with cervical spine injuries, and then validated this prediction rule at the second set of children's hospitals. Trauma patients that had 1 or more of these clinical signs had substantially increased risk of having a cervical spine injury, and this table from the paper corresponds with the red area on the job aid. So while it's important to note what these guidelines do include, it's also important to note what they do not include when you compare them to other cervical spine screening rules. Mechanism of injury, distracting injuries, or intoxication are not part of the decision tree. And the final analysis revealed that patients demonstrating high-risk clinical features had a 12% risk of having a cervical spine injury. The intermediate risk clinical features imparted a 3% risk of cervical spine injury. But most importantly, and I think the part of this that we're all most concerned about, is that patients without any of these simple, reproducible clinical signs had an exceedingly low risk of cervical spine injury. So thanks for your attention, and that's all I have for this talk.
Our next talk is by Matt from Indiana, and he's going to talk about variable management of pediatric blunt renal trauma.
That was great, thanks. This is a project we did through the Midwest Pediatric Surgery Consortium, so I want to recognize them as a contributor to this work. As you guys will probably know, the renal injury occurs in variable amounts of our pediatric blunt trauma patients, and there can really be a lot of complications, both in the hospital, hemorrhage, urine leak, but also long-term hypertension, long-term renal dysfunction. Non-operative management of blunt renal trauma is the mainstay for our hemodynamically stable patients, but there's a lot of variability in the management, both by institution and within institutions, and there have been lots of single-center management protocols published. So through the consortium, we wanted to explore the management variability and also look for any outcome differences. And we hypothesized that there would be a lot of differences within institutions and across institutions. Excuse me, this was multi-center, several years. All of our centers in the consortium are level 1 trauma centers, and we collected data from our EMRs and our trauma registry. You see the data listed there, both injury details, clinical management strategies, and then complications. To facilitate any sort of analysis with this very heterogeneous group, we put them into different subgroups, so low grade, AAST grades 1 through 3 versus high grade 4 and 5, and polytrauma versus isolated renal injuries to get those 4 groups that you see on the right side of the slide. We found 276 patients over that time period, and you see centers A through K, which represent our consortium hospitals, had variable number of patients over that study time period. And that resulted in those 4 groups that you see at the bottom, which included 75 patients or so with isolated renal injuries, both low and high grade. As you might imagine, there were very significant differences across these groups, both on whether they had any underlying renal anomalies, their ISS, GCS, et cetera. So let's look at variability in management, which I think is the most important part of this. When looking at the use or the recommendation for bed rest in these patients, so if you look at the percent or frequency of clinical use on the left, and across the bottom are those 4 grades, so or 4 categories, low and high grade, isolated, and then polytrauma patients. Particularly if you look in the low grade isolated column, the first column there, and each center has a letter, you see an incredible amount of variation across our centers in terms of recommending whether these low grade isolated injuries should get out of bed immediately. If you look at incorporation of urology, many centers routinely will incorporate urology management, such as those centers you see there in the high-grade isolated and polytrauma, and other centers don't incorporate urology consults in any of these patients. If you look at repeat inpatient renal imaging, again, it's all over the board, and some centers are using it selectively, and other centers are using it all the time. You can see one center highlighted here, G, in terms of post-discharge renal imaging, using it quite variably across these groups. Some centers use it all the time. And then looking at outcomes, the number of outcomes are incredibly low in this cohort. So we created composite adverse outcomes and also intervention outcomes. And there were no difference in composite outcomes, whether or not patients had bed rest ordered, they got antibiotics for a renal indication, or they had imaging after their injury. This is a busy slide that takes the low-grade isolated injuries out and looks at low-grade polytrauma, isolated renal injuries, and then high-grade polytrauma. And on univariate analysis, there were lots of differences in outcome across these cohorts, and I'm not going to belabor that for the purposes of time. So this was a small sample size. It made multivariate analysis quite difficult because of the small outcomes, and it was hard to really look at clinical indication for these management strategies. But as you can see, the non-operative management strategies for these patients was quite variable, and they were not always used in increasing use across injury severity levels. And there were differences in outcomes, and those outcomes were much more pronounced as you would anticipate in the polytrauma patients. So high-grade injuries likely, as you would expect, independently confers a risk for complications. And when you change all of these management strategies in low-grade injuries, probably of very little use. And there's an opportunity, we think, for standardization. This is the manuscript that came out in JTACS this year. We're proposing a guideline that we're going to implement and look at prospectively, and really just wanted to highlight the fact that much like the spleen and liver guidelines from 2019, this is going to focus on hemodynamic status, not injury grade, trying to decrease the number of interventions and radiology for our patient population, especially using clinical symptoms as a indication for imaging as opposed to just blanket imaging, and using ultrasound more frequently, and importantly, not using hematuria clearance as an indication for discharge. Thank you.
Our next speaker is Dr. Bean Yoshidi from Phoenix Children's, talking about prioritizing circulation over airway.
Good morning. Thanks to the program committee and my fellow trauma committee members for the privilege of the podium. I have no shady dealings to confess to you. And we're here to talk about changes in the classic sequence of resuscitation priorities. If you've heard about this CAB, we're going from the classic ABC to putting circulation first at the top. The memory aid of the ABC has been around for decades. It's simple, it's cute, it's memorable. Most importantly, it's logical, right? Without an airway, one can't breathe. Without breathing, one can't oxygenate. Without oxygenating, one can't perfuse, even if you are circulating. So why fix what ain't broke? Why change it at all? The motivation for this shift to CAB is driven from two angles. One is research-based and comes from the evolving understanding that peripheral oxygen levels remain fairly high even minutes after a respiratory arrest. The other is that pressure generated from compressions drops off quickly when compressions are paused, and it can take up to 15 compressions into the next cycle to build back that pressure head for coronary and cerebral perfusion. The other angle is very pragmatic, and it has to do with the training of lay rescuers, lay providers. So it is easier and more reliable to do so if you just concentrate on compressions. It avoids reluctance of airway or body fluid contact, avoids the delays of searching for a face shield or a face mask. In fact, to the point that hands-only CPR has even shown to be effective. The issue, though, as we hear this buzz about CAB, is that it's not actually totally revolutionary. By show of hands in the audience, who first did CPR training prior to 2010? I'll admit to it, that's a good crowd. So a lot of those folks with hands up probably recall that in 2010, there's a pretty dramatic set of changes that were put forth by the AHA and changed the standard guidelines and pathways that have been in place a long time. No longer look, listen, and feel for breathing. No longer begin with rescue breaths, but go right to chest compressions. Really concentrate on not interrupting those compressions, even for pulse checks. And even the idea of hands-only CPR was proposed at that point. This has been studied. We don't have time in these few minutes to get into the weeds, but it's been studied in adults, it's been studied in children, it's been studied in trauma setting. Randomized prospective trials have been done. It's clearly non-inferior. And actually, in some studies of out-of-hospital arrest, survivorship was increased by 10%. So there are a number of stakeholder agencies that have been part of this discussion and this move to change to CAB. I had to mention Royal Life Saving Society of Canada because here we are in beautiful Montreal, and my own first CPR and lifeguard certs are actually from RLSSC. But this move has really been driven by the AHA, the American Heart Association. This is the new line, right? CPR is as easy as CAB. And they truly say, if you find a person who's down and you don't know why, just begin compressions. Interestingly, the American Red Cross and Red Crescent International have drawn a line in the sand, and they're sticking with ABC. They've got a well-reasoned rationale for it. We don't have time for it here now. You can go to their website or chat me up in the hallway. They're sticking with it. In the military setting, they've left ABC. TCCC now goes with March, although the ABC sequence is preserved in there. We're expecting the 11th edition of ATLS later this year. And similarly, ABC sequence is preserved. What's changing, if you haven't heard, is that X for exsanguinating hemorrhage will go at the top of the list. So the bottom line is that we have the same core priority. And this buzz you hear about CAB is largely a pre-hospital phenomenon, a pre-hospital movement intended on expanding lay rescuer capacities. In that sense, the philosophy is somewhat similar to the Stop the Bleed campaign. So for us who are largely in the hospital setting, it's not actually so new, it's not revolutionary, and it's consistent with what we've been doing since the 2010 updates. But there is buzz and a lot of conversation about this. You're likely to hear about it from colleagues in other specialties, pre-hospital folks, and even just the general public. So we thought the membership would appreciate a bit of an update and background on this. Thank you.
Now we are going to finish up with John from Jacksonville, and he will be talking about tourniquet use in pediatric trauma patients.
Good. So we're going to finish up, tighten up, and talk about tourniquets. Tourniquets have been around since antiquity. In spoil alert, they work in kids too. It is a basic piece of equipment with really 4 very basic parts. There's the strap, the buckle, the rod, and the clip. And on the right side of the screen, there are pictures of 2 commercially available tourniquets. Stop the Bleed has been a hugely successful effort put forward by the American College of Surgeons. To date, over 4 million people have been taught how to stop bleeding in severely injured trauma patients. Again, tourniquets can be used for children when properly applied. For infants and small children, it's recommended to apply direct pressure because the tourniquets are too big, and this will stop most bleeding. To be effective, a tourniquet must be placed above the wound. That's important. You place the strap, you tighten the buckle. Whatever turning device is there, you need to turn that until the bleeding stops, and this will hurt. And if one tourniquet is ineffective, a second one can be placed proximal to the first tourniquet. And then it's very important to record the time that the tourniquet was placed so we can see how long this was placed. PTS, the Pediatric Trauma Society, supports the use of pediatric tourniquets, as does the Pediatric Traumatic Hemorrhagic Shock Consensus. So 2 quick studies that looked at effectiveness in kids. These were both observational studies in pediatric patients. They both used the CAT Gen 7 tourniquet. In the first study, they limited it to 3 turns of the windlass due to pain and showed 100% success in upper extremities and 93% success in lower extremities. In this secondary study, removed the 3-turn limit, and they had 100%. Of note, in this second study, the smallest child was 2 years old with a limb circumference of 13 centimeters. So military theaters such as Iran and Afghanistan have really gained a lot of experience with tourniquet. This is DoD data. And interestingly, this is just kind of a descriptive report, but they took care of almost 3,500 kids. Explosions and gunshot wounds were the 2 most leading causes, mechanisms of injury. And interestingly, tourniquet placement was their most frequently performed intervention. This study, published in our journal earlier this year, looked at a national EMS study on American kids, 301 patients, mean age of 17. And basically, it showed that tourniquet use is beneficial. Tourniquets placed by bystanders are better than EMS just because of the timing. And all of these showed reduced odds of critical acuity for these patients. So the enemy of good is better, and we have to be aware of prolonged tourniquet application syndrome. As designed, tourniquets are to produce tissue ischemia. And with prolonged ischemia comes a host of problems such as tissue, nerve damage, muscle weakness, compartment syndrome, and potential limb loss. So it is recommended that tourniquets be removed every 2 hours to assess for bleeding. If bleeding is stopped, replace it with a pressure bandage. So in summary, exsanguinating hemorrhage is rare in the pediatric population. Tourniquets have the potential to control bleeding and save lives. Early placement of pediatric hemorrhage control is critical. A tourniquet is a relatively uncomplicated piece of equipment that is easily applied. And tourniquets can be successfully placed in children and adolescents. It's endorsed by Stop the Bleed and the Pediatric Trauma Society. Adult tourniquets have been proven effective in children as young as 2 years old. And again, direct pressure is usually effective for infants. Improper and prolonged placement of tourniquets can lead to serious injury, and we need to be aware of that. Thank you.